let's talk about initiating treatment then. Somebody has HIV, and you're going to initiate treatment. What are you looking to do? What are your goals? I mean,
so the goals are, I think, really, really straightforward. It's to either maintain or restore health, right? That's the goal, right? And so to do that, we focus on getting people's viral load suppressed, as Eric was talking about, and you want to do it with the safest, most tolerated therapy possible. But we're really just trying to either maintain health if their CD4 is already high, or restore health if their CD4 is low. So I think that's simple answer.
okay, that's it.
Right.
You want to make them better.
Right.
Well, I could have told you that.
Right.
Well,
Yes.
I mean,
We can all go home now.
Right now we can
to put
all
a
go
little
home,
more
right?
nuance on it, if you don't mind.
Sure.
I mean, you're basically choosing a regimen that's going to suppress viral replication. And because we're lucky, we have a phenomenal surrogate marker for HIV health, and that is suppression of viral replication with antiretroviral therapy correlates so strongly with good outcomes that if you can do that, you're golden.
And that's why everybody's focused on viral load. I was just trying to get, so we all, the patients are focused on viral load, the doctors are all focused on viral load. But my point is just that, while that is really the goal is to keep people healthy.
All right,
right?
so
That's how we achieve it.
But there are always these two markers everybody's talking about.
Right.
One is the CD4 count, right, and one is the viremia.
Right, sure.
Right.
Viral load.
Viral load.
Right.
Okay.
Right.
What's the difference? Virus in your blood, viral load. What's the difference?
They're used interchangeably.
Semantics. I think that the providers would say viral load, but you're right. Viral load is the amount of viremia.
Is it better to look for viremia, or is it better, or viral load, or CD4 count, or do you use both?
Well, the thing is you can't really do anything about CD4 cell count, right?
Okay.
You can suppress the viral load, and most people, their CD4 count goes up, and that's a good thing. Or virtually everybody, it's stable. There are some people you suppress their viral load and their CD4 doesn't go up, or as much as you expect. And if there's someone at this table that knows what to do with that person.
Well, we do. We don't know what to do with that person, but we do know what to do with CD4s, and we know that when they're below certain thresholds, we give antibiotics to prevent them from developing opportunistic infections.
But Joe's right. I mean, I was invited to give a lecture at another academic medical center in Boston, and I said,
Wait a minute. There's another academic medical center in Boston?
And they said, we want you to talk about people whose viral load is suppressed, but whose CD4 cell count hasn't recovered. And I said, that's going to be a very short talk. Because we don't know what to do about those people. I mean, changing therapy doesn't really
Let me take
happen.
a dive into the deep end of the pool.
Right. Okay.
And
watch out.
this is going to be really tough. You initiate therapy when there is virus in the blood or the CD4 count is low.
Either one.
Either one.
Either one.
Yeah.
Period.
Now, the recommendation.
I would.
Who's in charge of this?
No.
Nobody.
Who's in
obviously.
charge?
Wait. So
Everybody gets
we are
treated
no longer
regardless.
considering CD4 count when making the decision to initiate therapy.
thank
Right
you.
now, the standard is everybody with HIV, if their viral load is measurable, which is almost everybody with HIV, those individuals should be started on therapy.
So you don't wait for the CD4.
We want to get the CD4 count because initially we'd like to understand if they're at risk for opportunistic infections. So we don't have to choose between getting a viral load or a CD4 count before starting therapy. We can do both, and we do. And the CD4 count tells us, are you at risk for an opportunistic infection now? And the viral load is telling us, okay, here's the starting point.
There are two different classes of information.
Yeah, the CD4 cell count also gives you a sense of urgency. So like when we have a newly diagnosed patient and their CD4 cell count is, for example, very depleted, under 100, under 50, even if they're feeling relatively well, we essentially tell those patients, this is your job to start antiretroviral therapy. This is your top priority, because in the old days, those were the people who had the prognosis kind of like, acute leukemia. I mean, they were the ones who died within 6 to 18 months. So they have to go on treatment immediately. The ones with higher CD4 cell counts, we like to start them soon as well, but it's not quite so
Why would you
urgent.
not start them on the day of diagnosis?
Well, that's a great topic and an area of research, right? I mean, there are several studies now that suggest that if you actually start people on their day of diagnosis, maybe they actually return to care better, maybe they suppress faster, maybe they retain and care better, because it's right. You're telling someone you have a serious illness. Oh, and by the way, we'll start therapy the next time we see you. But the flip side to that is, of course, that it's complicated starting therapy. You need to know some stuff about people, and you want to make sure they take it correctly. So it's a big step. So you have people that push back.
So
What about starting therapy after infection prior to antibody detection?
yeah.
Oh, well, yeah.
That's a
Different story.
That's a different story. If I can just mention one other thing about same-day starts. I think the reason we didn't start therapy on the same day as diagnosis in the old days was that the regimens were very complex. And so an entire industry was built sort of creating education about taking antiretroviral therapy and what it means to take medicines with and without food and what time of day to take them. And there were these counselors who were, you have to come back and go to adherence class and you have to come back and understand what viral load and CD4 means. All of that stuff today is antiquated. We don't need that anymore. Basically, people can take 1 or 2 pills a day and they're fine. So right now, same-day starts makes a lot of sense.
I am simply going to have to say this once, and I promise I'm not going to say it again, but I may not keep the promise. That's astounding. For those of us who were around at the beginning of this epidemic, and hearing you say that, jaw-dropping. So there's no excuse not to get on the ball here, not to do
There are
this.
practical issues, though, that we all have to deal with. Not everybody comes to us with insurance.
Okay.
Not everybody comes to us and we can literally write them a prescription and get them drugs that day. And not everybody who comes in, often having just found out about this, are ready to leave with pills that day.
All right.
So there may be advantages for select patients to do this if you can. Otherwise, it's as soon as it's feasible.